Once again, welcome to the University of Michigan School of Nursing Office of Global Affairs Coffee and Conversation series. This is our follow-up event that we conduct every year at the end of the Summer Institute to continue conversations about global health topics and to hear from speakers, experts, and collaborators from around the world. I'm going to go ahead and get us started because I know many of you only have this hour with us before you have to go back to work. So I'll begin by introducing our two speakers this morning. We'll have a presentation from them, and then these are meant to be more informal discussions. As you'll remember from last week, we had a really lively discussion at the end of the presentation. So we always leave time for questions and conversations at the end. So this morning we have two speakers speaking about work with, I'm sorry, I clicked the wrong button on my screens. Speaking about their work at Clinica de la Familia La Romana in the Dominican Republic and their work with patients who have HIV. Our first speaker is Dr. Pamela Baez. Pamela Baez completed studies at the Universidad Autónoma de Santo Domingo as a medical doctor in the Dominican Republic. She later obtained a postgraduate degree in public health at Middlesex University in London, where she worked as a research assistant for the Mental Health and Behavioral Sciences Department, working with drug users and with vulnerable populations. Since 2019, she's been working as both a medical doctor and the director of research in Clinica de Familia La Romana. In these roles, she provides outpatient primary care services to the community and specialized HIV care for Clinica de la Familia users. As a director of research, she has worked in the design and implementation of several research projects at Clinica de Familia, as well as working as a mentor for both national and international student rotation through the clinic. We will also hear from one of those students. So Chelsea Schroeder-Lozada, DNP, is a dedicated registered nurse with over 5 years of experience. She recently graduated from the University of Michigan with a Doctor of Nursing practice degree, specializing in family nurse practitioner. During her time at U of M, she received a concentration on global leadership, practice, policy, and earned a certification in trauma-informed care. Chelsea has actively participated in community health projects in Peru, where she co-founded a nonprofit organization dedicated to health and to environmental education. At U of M, she held the position of research and executive director for the Quito Project, collaborating with Universidad San Francisco de Quito, leading new health promotion curriculums and research initiatives. Her DNP research, in collaboration with Clinica de Familia La Romana, focused on spiritual beliefs among individuals living with HIV, resulting in the implementation of provider training in spiritual care. So please join me in extending a warm welcome to Dr. Baez and Chelsea Schroeder-Lozada. I will turn the screen over to you, Chelsea.
All right, thank you so much, Megan, for that wonderful welcome. Pamela is going to go ahead and start off by talking about Clinica de Familia La Romana, and then I'll end kind of talking about the project I did in collaboration with them.
Good morning, everybody. Sorry about that. My name is Pamela Baez. As Megan did a wonderful job in introducing me, and we're going to be speaking a little bit about what Clinica de Familia is and what we do and how we try to give like a comprehensive care to people living with HIV. Next slide, please. So first off, I want to start talking a little bit about where we are in the Dominican Republic. Is located in the Caribbean. It's an island that we share with Haiti. And La Romana is, if you look at that second picture, is, as you can see, is that little yellow spot. it's kind of like one of the smallest provinces in the Dominican Republic, and that is exactly where we are, where we are based on providing services, not just to La Romana, but for clients all over the country as well. Next slide, please. So Clinica de Familia was initially funded in 1999, basically with the purpose of reducing HIV mother-to-child transmission. That was the original mission of Clinica de Familia. However, over time, we have been growing constantly. And first, we were instituted as an HIV primary care center, and then expanded all of our services beyond HIV. And as of 2017, we've also have the Children's Global Health Fund in the United States that does a lot of collaboration with gathering funds for the clinic to keep on going with our activities. Next slide, please. So on a really broad strokes, we have several programmatic areas. Of course, of course, one of the biggest one is the clinical services that we provide, but we also provide services for community health, and then there's the global health student program. We have a research department and an adolescent program. So those are kind of like the 5 key programmatic areas of the clinic. Please, next slide. Next again. So when we talk about clinical services, we provide primary care to all of our population. We provide primary care services, but also through time we have been able to expand into a specialty care and consultation. We are not a second level type of care, so there's no like mittens and everything. It's all of it. It's consultation and very minor procedures that we can do. But as you can see, we have a pretty good array of specialties available for our population, and we also provide family planning services. Please, next slide. We're also doing diagnostics procedures. So we have imaging, including sonography, Doppler, X-ray, 24/7 BP monitoring, Holter. And we have recently started doing biopsy, whether most of them are like sonography directed biopsy. And also our clinical laboratory has an ISO certification, which is basically like quality standard or type of certification that needs to be renewed, which we basically in La Romana, we're one of the few laboratories that has this type of certification. Next slide, please. When it comes to, so specifically speaking about the cares that we do, when it comes to primary care, we still continue to work with mother-to-child HIV transmission, the prevention program, and we have been pretty successful in getting all those mothers that go into the program and having so that those children come out negative. So we provide follow-up, not just prenatal, but also postnatal for both the mother and the child. And also we do a lot of antiretroviral treatment and follow-up for both adults and children. And Clinica de Familia has one of the biggest pediatric HIV clinics in the Dominican Republic. Please, next slide. So we also have a social and community services department that provides that has a lot of focuses. Please, next slide. Starting off, we do have psychological consultation. I just want to know that the psychological consultation for the HIV population is free of charge if you are in the HIV program, but also for the general population, all of our services, we try to make it as accessible as possible, in that if we do charge for any of the services, it's usually below the market price that we're doing. And we provide services of speech therapy, occupational therapy, family therapy as well. We do have a social work department. We also have a social work department that serves as a link between those individuals who have very low resources, and that when we are able to contact with them and reach out to them, we are able to enable them with whatever service it is that they need, whether it's here at the clinic, but then depending on the needs of the patients, we can also let them get some external services if necessary, if there's a service that we don't provide. We also provide companionship when it comes to those individuals who are victims of interpartner and gender violence. In the sense that we have like a protocol for identifying those people that may be a victim of this type of situations, and if they are willing to report these events, then we kind of work alongside them so that they don't go along through all of this process. We have a camp that's called Hope and Joy. It's specifically for those HIV children, in which we organize like specific activities and excursions for children and adolescents living with HIV. We also have support groups. Most of them are focused around the people in the HIV program, but we also have a support group that is for women who either are living with or have survived breast or cervical cancer. Please, next slide. So for the community health, we focus a lot on in-home visits, specifically for those people who are living with HIV that are in a fragile or delicate health condition. And during those visits, we do a lot of and in not just clinical care, but we also do health education for the patient and the relatives. And we also provide palliative care companionship. Alongside the Ministry of Agriculture, we work on a garden program in which a lot of our people with specifically people with low resources or that they are willing to participate in, they can create their own gardens, and then whatever it is that they grow, they can sell it or they can consume it themselves. And we also have community peers to ensure that those people living with HIV are not lost to follow up. Please, next slide. Continuing with the idea of community peers, we do a lot of health promotion, specifically STD education in the community, in the community, and focus on key populations. That will be female sex workers, men that have sex with men, trans individual as well, and we offer them STD diagnosis and treatment. And we also work with PrEP and PEP to prevent the HIV infection. Please, next slide. So our adolescent program is a lot more focused on education, and it's divided in several specific activities. Next slide, please. As I said, the sexual education is pretty much focused on the schools. And we have educational sessions that is tailored for teens, and other sessions that are tailored for teens. And we also follow the AIM project type of methodology, in which we get these preteens and these teens to identify whatever it is that they want to do, what kind of obstacles do they need to face to obtain those goals, and what can help them to get those goals as well. We also have a youth community peers, in which of those children that are educated are encouraged to replicate or multiply the message that they're given. And we also capacity building offer for school and for parents about sexual education if they're interested in that, so that they could feel a little bit more comfortable talking about adolescents and their sexual health. And we also adolescent program coordinator support group for those people living with HIV. Next slide, please. So this is going to be my little corner of the presentation. The research department is basically, it's been growing over consistently over the last 10 years. Next slide, please. The main objective of the research department is improving the understanding of our patients' needs as well as our understanding of their community. And that is one of the main goals. And the other main goal is also measuring the impact of Clinica de Familia's intervention. So basically, we just want to know what are the needs and if what we're doing works or not. And we also try to contribute to the scientific community. Right now, we have over 40 articles published in peer-reviewed journals. Next slide, please. So this is just an idea of some of the projects that we've got going on, and some of the things that and some of the organizations that the research department has been collaborating with right now. We have worked a lot in the impact of COVID on the mental health of individuals, and we also have used a lot of infographics to improve communication between doctors and patients. And right now we are using WhatsApp, which is a mobile application to improve HIV antiretroviral adherence. If you have any questions about it, please feel free to ask. Next slide, please. And last but not least, there's the student program, or the global health program. So the student program at Clinica de Familia receive both national and international students that are willing, that want to have this global health social immersion experience. And for those national students, it's it's a step in their internship for most of those national students are people that are finishing their medicine school, and they usually work going into the community doing family health, but then they also do a lot of work with research and doing their dissertations and their thesis just as well as the international students who come in, and they could do something that it's more research-based or programmatic. Basically, it depends on whatever it is that the student is interested on, and that it is of value and benefit to our clients. And so now I'm going to leave it off with Chelsea. She's going to speak with us about her time at Clinica de Familia and what she did here.
Hi, everyone. Thank you so much, Pamela. Yes, so I want to just talk about the project that I did with Clinica de Familia. I had the privilege to work with Pamela and the other researchers at the clinic. And our project focused on the impact of spiritual care on the treatment and management of HIV. So just to give a little bit of background, so globally, 38.4 million people are living with HIV, with an overall prevalence of about 0.7% worldwide. In the Dominican Republic, in 2021, the prevalence rate was about 0.9%. So now with the implementation of antiretrovirals, we are now seeing that HIV is considered a chronic condition. And around the world, we are now seeing this increasing awareness of holistic approaches to chronic conditions like HIV. A holistic approach mainly just means not only looking at the physical, but also the social, emotional, mental, and spiritual aspects that affect the person. And a lot of evidence has showed that there is a large relationship between spirituality and health. So to give a little bit of background on overall religious affiliations in the Dominican Republic, 73%, my bad, identify as being religious in the Dominican Republic, with the largest being Catholicism or evangelism or Christianity. There's also other religions as well, but when this overall with clients with HIV can experience some stigma and discrimination that is associated with religion. And overall, understanding the spiritual and cultural influence that allow us to understand the population more and understand how we can influence significantly the high-risk behaviors. So the objectives overall for the project were mainly to identify the influence of Dominican and Haitian clients' spiritual and religious beliefs as it is applied to their HIV care and management. The second was to develop and implement a spiritual care training to be integrated into the care of those clients living with HIV at Clinica de Familia. And then also to evaluate providers' attitudes and self-efficacy, utilizing a pre and post assessment. So our project was completed in 3 different phases. So the first phase was the assessment of current spiritual practices of clients living with HIV, utilizing focus groups. The second phase was the development of the spiritual care training, and then 1 pre-survey before the training, just to evaluate those attitudes and self-efficacy of spiritual care. And then the third was the implementation of the training with the providers, and then completing 2 post-intervention surveys, 1 immediately after and then 1 month after. So the first phase, we had a total of 42 participants with 2 groups of Dominican, 2 focus groups of Dominicans, 2 focus groups of Haitians, and then 1 mixed group. Overall, we utilized during the focus group to guide our questions, the FICA tool, which is which stands for Faith, Importance, Community, and Application to Practice. And it's a spiritual care tool that can be used when gathering spiritual histories. Overall, the questions that were guiding the conversation were around personal faith, spirituality, the impact of spirituality on healthcare decisions, religious and community involvement, and overall, how can we integrate these practices into their care? So this is just an overview of the demographic information of the participants of the focus groups. Overall, just looking, we had quite a few more people that identified as Dominican than Haitian, as well as a lot more people that identified as female rather than male or transgender. And the average age was around 41. So to give a quick overview of the qualitative thematic analysis, so utilizing the themes from the FICA tool of faith, influence, and importance, community, application to practice, and stigma and discrimination was another set of questions that we added on to the FICA scale to allow us to just dig a little bit deeper into how patients with HIV are dealing with stigma and how that is related to spirituality or religion. So overall, we found quite a few of themes throughout. Mainly some things to point out in this was the main faith that was talked about throughout both or all of the focus groups was that personal faith is a belief in God. And then just another thing to highlight as well, while the application to practice questions, we didn't get a lot of answers. There are a lot of opinions about faith. A lot of patients felt that, or clients felt that, while they didn't feel that there was any barriers necessarily between their faith and their receiving care, They did have opinions that related to God giving wisdom to doctors, and that they believe that God can heal them. And then I'll just go briefly over the larger themes that we kind of found during the focus groups. So we found that patients felt that there was no barriers to care, while God's wisdom did help medical professionals. There was a lot of hesitation to disclose their diagnosis due to stigma. And the stigma wasn't necessarily related to the religion or spirituality. Dominicans seem to link mainly faith to mental and emotional well-being, while as Haitians seem to have this broader interpretation of faith, where they felt that it not only affected the mental and physical well-being, but also our mental and emotional well-being, but it also affected the physical as well. A lot of Haitians feared rejection from their religious community, and there was a lot of hesitation into talking in like religions that were beyond like acknowledging God. And there was also a lot of discomfort with the observation or disclosing beliefs such as witchcraft or traditional medicine. So when we go to the next phase of the research, we are going into the development and the implementation of the training with providers. So this is just a quick overview of the provider demographics. There were a lot of physicians and social workers and case managers that were involved, but a lot of variety. Overall, we had a lot more individuals that identified as female rather than male as well. So in this phase, we had the providers take the pre-intervention survey 1 to 2 weeks before the training. And this survey was the spiritual care competency scale, but modified into 17 items, the items that were the most relevant to the training that we were doing. And then the post-intervention surveys were one immediately after, one month after, and it not only included the 17 items in the pre-survey, but also 16 other items that dealt with the accessibility and feasibility overall of the training. And a little bit about the training. So the training was utilizing the focus groups, the information from the focus groups, as well as the FICA tool, and then also allowed for discussion around these topics, and was implemented using evidence-based practice. So overall, the quantitative findings that we saw. So in the Z-score and the p-value that were found between the pre and post immediate after survey was that we saw that there was some positive correlation, a slightly higher than statistically significant, but overall there was a lot of promise there as well. But when we compared the pre to the 1 month survey, it was significantly lower than the immediate after post survey. Overall, between the 3 surveys, the p-value wasn't statistically significant, but overall we did see positive results. And just to give an overview discussion about the research we did, is the focus groups really did uncover a lot of key cultural and religious distinctions, and we were able to explore a lot of the themes. And while the pre and post surveys didn't meet statistical significance, there was a lot of promise there, and there were areas for improvement as well. We did see a lot of this important relationship between healthcare and spirituality, and there were a clear relationship between the attitudes and self-efficacy of providers in delivering spiritual care after the training. So overall, recommendations, implementation, when we're looking at this doing possibly a larger sample size for focus groups with not only patients living with HIV, but also patients living with other diagnoses. We may find similarities and differences in those findings as well. And then the interviews, possibly instead of focus groups, could allow for the possible hesitation around other beliefs and give us some broader data. And then larger sample size for the provider training as well. And then maybe doing these repeat surveys in 6 to 12 months to get a little bit more data. So I would like to just acknowledge the collaborative efforts of my colleagues at Clinica de Familia, and then the support from University of Michigan School of Nursing, Office of Global Affairs. And then I also like to thank everyone that was able to give me financial support as well for this project. So thank you everyone for your time. I really appreciate the time to speak with you.
Great. Thank you so much to both of you. It was great to get a taste and an introduction to the work being done and see what sorts of research students are able to do and the sort of holistic way care is being approached. So if Chelsea, you can go ahead and stop sharing, and that way we can sort of have many people's faces up. And folks who are listening, you can either type a question in the chat and I will read it, or just unmute or raise, or maybe there's enough of us, probably raise hands or unmute to ask a question. And while you're thinking, I will start off by asking a question of Dr. Baez, who mentioned the WISE app. So, and you said, feel free to ask questions about it. And that piqued my curiosity. Can you tell us what that is and how it's used at Clinic?
Yes, the WISE app is a project that we are doing in collaboration with Columbia University. It's an application that uses smart caps basically. And right now that it's a research project that we've got going on. But the application has already been developed for English-speaking population, and now it's being translated into Spanish. So basically, we are testing whether it works or not. So you have your smart cap and you have your app installed in your phone, right? And every time that you open the smart cap, there's a signal that goes somewhere. The technology goes a little bit beyond me, but then it comes up in your application. So it's a very track your adherence for those people that have difficulty remembering whether they drink their pills or not. But it's not just an adherence tracker. There is a section of it that has information about HIV and how to, and maybe little tips on managing your health. You can set up alarms or things like that so that you can basically remember to take your pills every single day. And then there is something that we were a little bit excited about because we had never done that before, is that there is a chat with the clinic type of box. So all of the clients have access to the WISE app team, and some of the questions that we have received have to do with how do I set this up or that, but it's something that we had never done before, have a direct hotline to those clients like that, to a doctor. In this case, that would be me because I'm the only doctor in the research team. We had thought that we would be getting a lot more questions. We didn't, but that's great because that means that they feel like that the people that do have the application, they feel like they're managing their health pretty well. So we have two groups. One group, and we're following them up over a year. One of those have the application on the phone, the other one doesn't. And so we are going to be measuring the comparisons in their viral load, their CD4, their general health status over that year to see if the application was efficacious for them. Yeah.
Great.
Yeah.
Thank
and
you.
so, and something very funny happened is that most of those people that have finished their follow-up, they was like, can I keep the bottle? I would like to continue using the app. And we're like, okay, which we didn't expect either. So I'm guessing there's a lot of interest in that.
Yeah, that's worth tracking just from how good is the user interface and was it useful to people?
Yeah.
Sort of just a tally, at end of study who requested, how many people spontaneously requested to keep the app. Cool. Audience, what questions do you have? I had one for Chelsea, but she answered it a bit at the end. Do you think the focus groups would have been different if they were sort of single faith in a nuanced sense? I don't know if it's true in the Dominican Republic, but I know in other places, sometimes there are some tensions that aren't always spoken, but are there, for example, between Catholics and evangelical Christians. I remember working in Latin America 20 years ago, 30 years ago, and being very surprised that the Christians didn't think the Catholics were Christian, and there were definitely tensions. Do you think having mixed groups led to people only being comfortable talking about the common ground, and that the common ground is a belief in God, right?
Yeah, I guess I never considered that, but definitely I think that is a possibility, for sure. The thing that we noticed the most was bringing up any other religion was just not going to happen. So that was just one thing, like talking about anything that like witchcraft, traditional medicine, botellas, like anything like that. It was just not. A lot of people may have said, "Oh, maybe I've not practiced it, but I've heard about it," but they weren't willing to discuss whether they have really partaken in it at any point in their life, or discuss that they believe in it in any sort of way. Even though we know that a large population in the Dominican Republic do believe in witchcraft and traditional medicine. And so thinking about that, it definitely would either be thoughtful to bring in people that we know already believe in those things and then ask them specific questions, or do interviews like one-on-one where they wouldn't have that hesitation because there's other people around, and feeling like that type of like hesitation due to rejection. There is a lot of stigma around those other beliefs. So yeah, it was very interesting. A lot of people just like when we talked about it, they were like, no, 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 I would never do that. I don't do that. I don't believe in that. So it was definitely interesting.
Yeah. And then they always knew a whole bunch of people who did believe and practice it, but
Yeah.
they never had. And I think that one of the things that Chelsea and I discussed as a potential future intervention would be maybe speaking to people who do practice witchcraft specifically, or doing one-on-one interviews like Chelsea just said. However, for the focus group, we try to keep like kind of like a language that would be as neutral as possible, because we kind of didn't want it to I don't know, to the conversation to suddenly become Catholic belief versus evangelic belief, so we were very speaking about just plain faith or your religion or your faith or anything like that. And I think that kind of it helped a lot in getting people to open up, but I think that it limited a little bit into looking into those nuances that you're speaking about, and maybe that's something that we can think about in the future.
Yeah, definitely.
Mm-hmm.
Thank you. Great answers. Is there a role for an anonymous survey? Right. So people were shy with each other.
Mm-hmm.
Would they be shy about witchcraft with a researcher affiliated with the clinic, even if it was alone, do you think?
I think not. I think
okay.
I think it more than anything would depend on the way that we approach them. more you know that like even if we try to make it as open as possible, like you can never really account for like inner stigma or like self discrimination a little bit. So maybe in that way, doing a one-on-one interview or an anonymous service may be something that can give a lot of information. Maybe reaching out into the community, because of focus groups, the people had to come to the clinic, so we kind of didn't see those people that weren't able to come into the clinic, and that's a limitation that we also kind of have.
Yeah, and I mean, we did have one person out of all of the focus groups that said they didn't believe in anything, and during that during that focus group, you could tell like there was like a little bit of tension in the
Yeah.
fact that they were saying they didn't believe in anything, and everybody else was like, "How can you not believe in anything?" Like, just. And so you could tell that because of the environment that there was definitely some hesitation to discuss or disclose.
I was wondering about thanks again for the presentation. I enjoyed listening to it. So in regards to like the HIV, and then in regards to like what you're talking about now, like the beliefs, so what are some of the thought process of like the native of the community there corresponding to like spiritually, like HIV, what condition is that to them? Does that make sense?
Yeah. Yeah, so a lot of people felt like it was like this divine test from God. Like there was this belief around that HIV, while like they were given HIV from God, that it was some type of divine test or intervention of some type by God. But a lot of them said that their faith, even though before and after diagnosis, didn't decrease. Like they either had more faith or the same amount of faith that they did at the time of diagnosis from previously. So there wasn't like a lot of they felt that it was some type of test from God, but yet there was no decrease in their faith either way. So it was very, very interesting.
That's interesting, yeah. So then mental health wise, how does the community do with what was the rate of HIV, or like is that affecting their mental health, or just faith wise, it just like you said, it's just
So a lot of them said that stigma really affected their mental health.
or
That the
okay.
stigma
The condition
around
itself.
HIV was what really affected their mental health, but they felt that having faith allowed them to have improved like mental health overall, was a lot of the common. And one thing we did find that was very interesting as well is like a lot of the focus groups with the Dominican population had stated that they didn't think that the faith really affected their physical well-being at all, that it only affected their mental and emotional well-being. Whereas the Haitian community or the Haitian population that we interviewed really felt that it affected like the whole person, like that they had a more like holistic view of that than others. So it was very interesting just to kind of see like the different nuances, I guess, of how people describe faith and what they feel that it affects in their life, and like how HIV overall, the diagnosis affected their faith, which a lot of them said it really didn't affect their faith. So,
Thank you.
yeah.
Other questions, folks? Just for background information for our audience, what's the situation for Haitians in the Dominican Republic right now in terms of access to care?
But when it comes to access to care, right now it's a little bit of a complex situation, in the sense that most of the, or well, not most, but a lot of the Haitian population is undocumented. So first of anything, there is a lot of fear that if I go to a hospital or if I seek healthcare, I'm going to get caught by migration. I'm going to be sent back to Haiti. So I think more than anything, the first obstacle is that some of the Haitian population does not know that they may have the access to care that they do. But however, I think that from the public health point of view, like if they would go to a hospital or if they come to the clinic or specifically or any other public hospital, they would receive the care that they need, and we wouldn't be like calling migration or anything because you're Haitian or anything like that. So they do have access to care, however, it's limited by those structural barriers that I just mentioned. And then there's also, some other barriers, like for example, if they wanted like if they're not documented, of course they don't have any insurance, so their access to care is limited in the sense that there is only so many different places that they can go through, and most of them are very public based, and there are some deficiencies in the public health system in the Dominican Republic.
Thank you.
Yeah.
Other questions, folks? All right. I think that our audience seems very quiet.
I do have one question.
Oh, great. Thank you, Judith.
Thank you. So I know that the clinic was first created for women and children care, and then expanded towards HIV care. Would you say that you have had like a pushback from the community or the government since you have expanded your services? And what have you done to try to help educate the community or whoever regarding that?
I don't think that there's been like pushback per se from the community or the government in specific. I mean, the what I could tell you is that since we started working with pregnant women living with HIV, and preventing the transmission of HIV from mother to children, and because the clinic started working with very specific key populations, like we have there's a little bit of a moniker that is called like, oh, that's the HIV clinic. And like for a while there was that aura, like if you go to Clinica de Familia, it's because you have a HIV, So at the beginning, that transition took a little bit of time. There's still people that hang on to that moniker and the thing, because word of mouth is really hard to battle. So I'm saying that that's kind of like the biggest struggle that we've been having. However, it's been so long that we are getting more clients that are HIV negative than people who are HIV positive. That is slowly, very slowly, going away a little bit. And one other thing that has helped the clinic a lot is that about 3-4 years ago, we started working with insurances, not just the government insurance, but also private insurance. So, we added the fact that we have lower than the market average prices, and then you add the insurance. So we have a lot more people coming in that, and that's given like a lot of acceptance from the community to the clinic as well. Yeah. I don't know if that answers your question in any way.
Yes.
Yeah.
Yes, it does. Thank you so much.
Sure.
Yeah. And that was sort of an important clarification, that you actually started with an HIV positive population. So the battle went the other direction.
Yes.
How do you convince people that just anyone can come there for blood pressure or diabetes?
Yes, and it's really wonderful, like for me as a doctor, to see a lot of, because for example, me, I work mostly with HIV population and with the HIV program, and we get people from all over the country. Like we are in the eastern part of the country, and I get people that to get to La Romana, they have to be on a car for like 8 hours, and they act from San Juan. I had a patient one, which is like all across the country, and they will be like, I like to come here because every other place that I've been to, like when you are in the HIV program, your appointment card or your ID for the clinic is different. Everybody knows, and right away everybody knows that you're living with HIV. Whereas here, you get that same treatment for everybody. So there's, it goes back to stigma quite a bit in that sense, and I think that's basically the biggest obstacles that we have encountered when it comes to resistant.
Great. Thank you. No, that was a really good illustration of, that even for people with HIV, the advantage to now being perceived as a full scope primary care clinic and to doing business in a way that doesn't signal which service someone's here for, really makes it much more user-friendly and accessible to come. Great. Other questions, folks? I'm just trying to pause long enough in case people are shy. All right. Yes, so you're getting thank yous for your hard work and for presenting today and sharing your experiences, and some applause. I believe, yes, everyone is saying, good job, excellent presentation. Thank you. And thank you from us at the Office of Global Affairs. And we hope to see you back. I already have a million ideas about, oh my gosh, Pamela said this about, they just sort of thinking about that dual role of religion and adolescents who are HIV positive. We have a colleague here who's worked for her whole career in Uganda with adolescents with HIV, mostly with kids who were born exposed when antiretrovirals were less prevalent. But that sort of double thing about religion potentially being, and faith being, a source of strength, but sometimes also a rationale for staying very, very hidden with your diagnosis. So we'll maybe make some connections later offline, but Massey was not able to join us today. All right. Thank you, everyone, for attending. Thank you again, Dr. Baez and Chelsea, for presenting. And have a good morning, everyone.